Good afternoon and welcome to the Minnesota Department of Health Monthly Stroke Education Series. My name is Catherine Johnson and I will be your co-presenter today. We have mysterious case stories for you for the theme of Halloween. This webinar is part of the MDH Monthly Stroke Education Series. The webinar is being recorded for future viewing and you can catch all of our programming on the MDH Stroke Program YouTube playlist. Your lines have been muted upon entry. Please ask questions and typing them into the chat throughout the presentation. If we don't get to all of your questions, we will try and address them in a follow-up email. We will start out with program announcements along with learning objectives, and then we will have case presentations from Joni Soames, Dr. Danya, and Dr. Edward Laban. The 2022 Quality Improvement Awards for Hospitals, QI Awards, has closed the application process. The EMS QI application is now available on the Emergency Medical Services for Stroke webpage. Please contact me, Catherine Johnson, at state.mn.us. The deadline to apply is actually this Friday at 5 p.m. The Minnesota Stroke System is kicking off the fourth round of designations, or Designation 4.0, April 2023. If you are a stroke coordinator, do not miss this training to learn all about Designation 4.0, all things Designation 4.0, including a refresher on requirements, resources, application updates in the Minnesota Stroke Portal, and what you can expect at a site visit time. A calendar invitation will go out for this webinar in early November. Reach out to Michelle Gray-Ansari if you have any questions about this designation timeline. So our learning objectives are: name 2 signs of a right-sided stroke, understand the key features of rare stroke syndromes, and identify the involved cerebrovascular territory for presented stroke cases. So a little bit of Halloween fun facts since we're quickly approaching Halloween. The largest pumpkin was actually grown by a Minnesotan horticulture teacher from Minnesota. The pumpkin weighed in at the Safeway World Championship Pumpkin Weigh-Off. It weighed a whopping 2,560 pounds. This teacher also grew the largest pumpkin in 2020 at 2,350 pounds. Quite a sight. It did break the largest pumpkin in North America for this year. And for those that don't know, we do have the Halloween capital of the world. It is in Anoka, Minnesota. It actually started in 1920. It is believed to be the first town celebration to celebrate Halloween. And they started off to keep the kids keep the town's kids from pulling pranks throughout town. They were letting cows out and all sorts of mischief. So they started the Halloween celebration, and their Grand Day Parade is actually this October 29th from 1 to 3:30. So if anybody's interested, I'm sure it's a sight to see. Some of the haunted places, when I was researching for Minnesota, we have quite a few, but these are just a few that are some of the most haunted. There's the Palmer House in Sauk Center, Minnesota. There's said to be a ghost named Lucy in room 17. She likes to slam doors and drop the temperature. Also a ghost named Raymond in room 22. So feel free to check those out if you're daring enough. There's a soap factory in Minneapolis. There's ghosts of previous soap factory workers there. And for those that may not know, I didn't know this until I was researching, First Avenue used to be a Greyhound depot and is said to be haunted by a woman who committed suicide after losing her lover in the war. Also, many ghosts who have passed on at the station as well are said to have haunted First Avenue. Artists report that their headphones and equipment moving on its own. So multiple reports. So it might be a good place to check out. Schmidt Brewery is also another one. Lots of paranormal activity from accidents of brewery workers. And the last one is Four Paws Restaurant, which unfortunately is closed currently, but it is the mansion it's made is said to have haunted the attic along with her lover, Joseph Forepaw. And with that, I'm going to turn it over to Joan Soames, a nurse who has a mysterious diagnosis case. Joni, take it away.
Thanks, Catherine. We were asked to come up with a case, and some of you know that I worked in the emergency department at St. Joe's Hospital for a long time and saw a lot of different stroke cases. And this particular case is kind of a combination of a couple patients, but the part that stuck out to me was the case of the non-painful broken arm. So Catherine, if you want to move ahead, we'll talk to you a little bit about the patient who presented. So in triage, Gertrude, and I made up a name and I made up some pictures that kind of represent what was going on just so that we could protect patient privacy, was an older adult, although 74 is not so old anymore in my mind. She presented with her family. She had a very obvious deformity of her left forearm, didn't seem to have any other signs of trauma, so we're busy thinking that Gertrude was actually a trauma patient. And she really denied any injuries, and she also denied any pain. What was a little odd was she was oblivious of what looked like a really painful left forearm. Her family brought her in. They gave us a little bit of a history. They said that they lived with Gertie because of family circumstances. They were the ones telling us how active Gertie normally was. So she wasn't your uh, or maybe I should say she was your more typical older adult now who's busy out there walking every day. She did most of the cooking, the cleaning, the laundry, and the childcare, and she was a volunteer at church. So you know that this was a very active woman, and it was a little unusual that she presented. And if you go to the next slide, some of the things that you noticed even about Gertie was that she just didn't seem to ring true. We assisted her into a chair, and the really odd part was as we moved to the left of her, the way our triage was set up, she suddenly stopped interacting with us, and it was like we weren't there whatsoever. She didn't look at us. She was busy looking at her family, but she seemed to stop interacting. Her family started to answer more of the questions for her, and they said normally she was quite a jokester and very chatty type of a person, but they said her being really quiet was kind of unusual. And you notice I had to put together a string of pictures, but you notice that Gertie is not looking towards the person at the computer, but is actually looking off more to the right. And then I put some family people in the background just to kind of give us an idea of what was going on. If you go to the next slide, the story continued as we were getting some triage history from her. Is that we learned that during the lunch dishes, Gertie went to take a nap. The family says this was unusual for her, but the reason I put this in there was because it gave to us a last known well. She had done lunch dishes, and when they brought her in, it was about an hour after she'd gone in to take the nap that the family noticed when she was coming out of her room, she seemed to be stumbling and she fell. Oddly enough, Gertie didn't seem to remember this. She couldn't understand why the family was so upset. And one of the things we noticed was that Gert didn't really seem very talkative. She did answer questions appropriately, but very simply. She was alert, oriented to time and place. She knew where she was, when it was. But if you asked her a question, she would only answer with like one word type answers rather than several answers to go along with it. If you go to the next slide, you also notice that she didn't look at us. Her gaze kept drifting off to the right. And what really made us just grimace was she kept moving her left arm around. And it was like, holy cow, wouldn't you think you'd protect that arm and hold it still in your lap? And you noticed in the earlier picture, she was holding her right arm in her lap, but her left arm, she was moving all over the place. She didn't seem to notice that it was broken. And that was just, it was kind of seeming a little odd. Further medical history on Gertie was she basically was very healthy. She took 2 baby aspirin every day. She took a beta blocker because she had atrial fib, and she had no allergies. And so the good news was whoever was out in triage that particular day, something was tingling in their gut, in their spidey senses. And they kind of wondered, if you go to the next slide, we asked the question, would your spidey sense tingle ever make you think that this was a stroke coat? Remember, she looked like she was having a trauma type of a thing. And the reality was, yeah, she had a broken arm, but did she have two things going on? So Catherine, if you want to highlight like the next 3 or 4 slides. So her level of consciousness was good. When we had her smile, there was no facial problems. Yeah, she really, I mean, when she's got a broken arm, you kind of wonder, did she have drift or not? But ultimately, arms and legs didn't really seem to be badly doing badly compared to her other arm. And we kind of assumed that that left arm wasn't doing as well because it was broken. As far as language, she really was able to speak okay. Visually, I think there was a slide. It was like when we talked to her, she didn't see us on the left side, which was kind of the first clue. And then if you highlight the next slides, um, there was how was she doing ataxic? When she walked in, she seemed fine. When we tried to check the best language, she seemed fine. Her speech seemed fine. The one thing that you noticed that we missed in this little list that we used to use in our emergency department, which was more the brief NIH score, when we were in triage, was that we didn't actually see what her gaze was and what her visual was. And so what we realized was left-sided, she did have complete hemanopsia and wasn't seeing us. Yet when we tried to do her vision by poking our fingers at her, she actually blinked, which was really kind of weird. The other thing we realized was she had extinction. So if we were to have done an official NIH scale on this woman, we really wouldn't have come up with a lot of numbers. And even if you wanted to count the best motor on that left arm, it's kind of like, well, was it because she was having a stroke? Or was it because she had a broken bone and we were just kind of forgiving her for not moving it as well as it should? So for whatever reason, the gut told the nurse to go take the patient and call a stroke code. And if you go to the next slide, even though this is not her actual CT, it's one from a very similar 74-year-old who had a similar right M1 occlusion. Both patients, by the way, the patient that this picture came from was successfully treated, as was Gertie. And the key was someone had enough oh my gosh, something's not right, to call a stroke code, and ultimately she was treated. If you go to the left side, some of the things to think about when you have someone who has a clot or a stroke going on the right side is they have different symptoms than the typical person that comes in with the clot on the left side. These are folks that tend to more have like impaired judgment. They have the left hemanopsia, they have safety and impulse problems, they have short attention spans. They may, even though Gert didn't have a lot of hemiplegia, paresia, they may have that. The biggest thing is, especially in Gert's case, she denied or minimized problems. She did not realize that she had a broken left arm because she had neglect going on. And one of the other things that is common with these folks is they have a spatial perceptual deficit. And probably the reason for her fall was that she actually didn't see the doorway that she walked into. And that's what led her to fall, and that's what led her to a broken arm, and that's what led to the distraction for the nurses when she was brought in. And I think the key thing to remember is that you can have two things going on with patients, and sometimes it's a stroke as well as an injury that's happening. The next slide just gives us some of the other symptoms. As I mentioned, they bump into or trip over things. They may not be able to find things on the left side of their body. If you're ever feeding someone who's had a stroke that involves the left side, you'll notice they don't eat the food on the left side of their plate, or if they have things on the left side of their tray, they don't see it, so they totally ignore it. They tend to gaze to the right and ignore people on the left. And I can't remember the number of patients over the years that I saw, if I walked into the room, they would not answer me even if I was on their left side, but if I moved to the right side of the bed, suddenly they would interact. And it was the strangest thing, but you had to remember to try going to that right side of that person so that they would see you and recognize you as well. The interesting thing is, even though they react as if they're blind, sometimes that vision does remain intact to confrontation. And so you still need to check the visual fields on these patients. And some of the things, I hadn't picked this up on any of my patients, but as I was researching it, they said some lose their hearing as well. And most of them literally interpret what is being said, and they don't recognize things such as sarcasm or complicated questions. You have to make things very simple for them. The next slide just reminds us, and this is just, I guess, my general, I always talk about this. Anytime someone has a sudden change, I always remind them that it doesn't have to be just right-sided weakness that the person has. Anytime they have any changes in their ability to get around or pay attention, if they have changes in their ability to do things, and I can't remember the number of times we've had patients that came in that suddenly couldn't read or suddenly couldn't do math, things like that, which you go, oh, they're just being goofy. But the reality of it is, depending upon which part of the brain is being involved, that could actually be a stroke that's happening. Frontal lobe has different types of things like they can't make strategies for new situations. Their personality suddenly changes. They suddenly have bladder control issues. And when family brings in patients with abnormal or unusual symptoms, we need to start thinking, could this be a stroke that's affecting the person? The temporal lobe area typically causes visual or memory problems. Facial recognition and music appreciation are some of the things that get involved there. And of course, patients that suddenly present with visual problems, you kind of wonder, is there an occipital lobe thing going on? Last slide, I'm not going to read through this last slide, but I just saw this one and I thought, wow, this is kind of a fun slide. It's got all the different things we do and all the different parts of our brain. And to me, whenever I'm taking care of patients, I always in the back of my brain, as it were, have a little question wondering, could they have a stroke that's going on and how is it affecting their daily life? One of the things I've recently been promoting when I talk about stroke to other folks is to remember, if suddenly someone can't do what they normally do, the Rankin scale, you need to start thinking, is this something that is a stroke that's happening that's not clicking enough boxes for the NIH? But it is clicking a box for the Rankin, and do we need to think about calling a stroke code on these patients? So promoting that early suspicion and early call is kind of where I always go. And my last slide finally is the one that you can tell which kind of brainer I am. I'm the one that likes to have all kinds of fun things. There's two different versions. There's the scientific version, and there's the artsy person, and there's the organized person, and there's the kind of whatever you want to call me person, because you can tell I am a right-brained person. If I had a stroke over there, I'd be in really big trouble. So with that, unless there are some questions, I'll turn it over to the next speaker.
Wonderful, Joni. Thank you so much. Such an interesting case. I'm glad it was caught early. We're going to turn it over next to Dr. Danya.
Hello, everyone. I'm very happy to be with you here today. I will present a mysterious case that challenged us a lot and had several challenges after to diagnose and further treat. So let's start. This was a 77-year-old pleasant woman. She had a non-medical history of hypertension. She was diabetic. She had hyperlipidemia and had a history of atrial fibrillation and wasn't taking any anticoagulation. Her presentation to the emergency department was due to aphasia and fatigue. So pretty much non-specific symptoms that she came with. She endorsed that she was drinking less fluids, urinating less frequently. She lived alone. And when we tried to verify when was her last known normal, it turned out to be 3 days prior to presentation. Next, please. She had an extensive workup done, and we decided to get a brain MRI, which showed the following. So here we're able to see tiny little stroke in the right thalamic area, a larger one on the left thalamic area. So, and then the other slide shows you a tiny stroke in the left cortical area. And looking at the pattern and distribution, that was really bizarre. Just reminding you a little bit about the anatomy. So both thalami receive their blood supply from the posterior circulation, and then this area is supplied by the anterior circulation. So how could we have a stroke that presents in the same time affecting the posterior circulation, both sides, plus the anterior circulation. Next, please. I tried to include the slides to show you that the stroke on both thalami happened pretty much in the same time. So you can see the restricted diffusion in the first slide, and then it correlates with the ADC. And then the flare also shows changes, which goes with the timeline of the last known normal of 3 days. Next, please. So again, going back to that bizarre distribution of the stroke, how could we get a stroke in 2 different vascular territories that affects the posterior bilateral circulation and the anterior circulation? So let's find out. Here is the vessel imaging. You can see both internal carotid branches. So on the right side, the diameter looks good. Not much evidence of atherosclerosis on this section. The other side, though, it shows a significant atherosclerotic plaque. It did have narrowing, and I'm going to show you in the coming slides too. Next. So here is a sagittal view. You can see the steno. I hope you can see the stenosed left internal carotid. So when we measured the stenosis, it turned out to be 70%. So the left internal carotid had significant stenosis. But remember how the MRI looked like? This won't explain the bilateral thalami involvement and the new left stroke altogether. So let's see the next slide, please. Now, these were helpful images. And I don't know if any of you was seeing such a variation in anatomy like the one that we were able to find here. So this slide, the first one, shows you the both the internal carotids. Look at the left internal carotid. Look how this artery goes around and comes out from it. You can see it better on the next slide, the second one. There is a connection that comes from the left internal carotid and goes all the way to the basilar artery. So actually, this is a connection that comes and connects the anterior circulation, the left side to be specific, with the whole posterior circulation in the basilar artery, which I've never seen a case in my life before this one. Next slide, please. So what did we do for this patient? We initially started her on aspirin, and then when we discovered that she had atrial fibrillation, we decided to switch to heparin drip. And then we consulted vascular surgery right when she came in because she had the evidence of the significant stenosis in the left internal carotid. Vascular surgery decided to do a carotid end arterectomy procedure, and she got it done on the 3rd day of hospitalization. Her procedure showed a significantly ulcerated plaque in the left ICA, and other risk factors were pretty well controlled. Her LDL was only 10, and her A1C was 7.3. How did she do after the procedure? Her aphasia improved and continued to improve. And then she was discharged on day 4 on aspirin, Eliquis BID because of the atrial fibrillation, plus a high intensity statin. Next, please. And then when we followed her up 2 weeks after hospital discharge, her aphasia had completely resolved. She kept suffering from mental fog, slowness to process her information, And then she had several low blood pressure readings, and we tried to adjust the doses of the 3 blood pressure medications she was on, and then stopped hydralazine, which improved her symptoms. Next, please. So going back to the mysteriousness of this case and that weird vessel that connected the left circulation with the posterior circulation. So this is called a persistent trigeminal artery, PTA. And this is an embryological vessel that's supposed to involute in the embryo, but in her, it actually persisted. When we did literature review, we found out that this vessel could persist in 0.12 to 1% of the population. So pretty rare. And you know, people could go on with their lives without experiencing any symptoms or deficits with such a variant anatomy. But in her, because she had the significant 70% carotid stenosis in a very proximal area to the origin of that vessel, and then that plaque showered to the vessel via the vessel to both the basilar artery, and then it gave us the bilateral thalamic strokes, and it showered to the left MCA territory. So hence we saw the other stroke too. And persistent trigeminal artery, it's classified into 2 types: Salzmann type 1, which our patient had, and Salzmann type 2, and I'm going to explain the difference in a second. Next, please. So here we find better imaging for the origin of that trigeminal artery. Type 1 basically means that it's going to supply the proximal end of the basilar artery. So the PCAs will be really involuted. The proximal part of the basilar artery will be almost gone, while type 2 is a variant that goes directly to the superior cerebellar artery. And then you will have PCAs in the second variant. Next, please. Now, the last slide and the final challenge with this patient was how to perform the end arterectomy. Because remember, she had the persistent trigeminal artery just very close to the plaque. So in carotid end arterectomy, they have to clip just distal to the plaque area. And in her case, if they were able to clip distally, they would actually block off the blood supply to the posterior circulation because it's dependent on that trigeminal artery. So in her case in specific, they had to use a shunt. And we thought that was another challenge, but thankfully it was successfully done. Patient improved, and we got major learning from this case. So I hope you enjoyed the case and learned something. Thank you.
Thank you, Dr. Danya. Thank you for such an interesting case and mysterious. Our final case presentation tonight, or this afternoon, excuse me, is by Dr. Edward Laban. Take it away, Dr. Laban.
Hi, I'm Eddie Laban. I'm the Hennepin Healthcare Stroke Director and affiliated with the University of Minnesota. My stroke case is really more of a stroke story, and in the theme of Halloween, I think you'll find it plenty spooky. All right, next slide. So before we get started, I'll give you a quick history of the Odyssey, because that's what we're doing. We're retelling the Odyssey through the eyes of vascular neurology. So the Odyssey was composed in the 8th century BCE by the blind poet Homer, but maybe had influences by the Epic of Gilgamesh, which was written in 2000 BCE, and is part of a very long oral tradition with many variations. And because of that, I felt comfortable taking a bit of a creative license. Next slide. So at the end of this talk, hopefully you'll be able to understand key features of several rare stroke syndromes, localize these syndromes to discrete areas within the brain, and identify the involved cerebrovascular territory, or at least the stroke mechanism. Next slide. So our story begins with Odysseus at home in Ithaca with his wife Penelope and his newborn son Telemachus. The Trojan War has just started, and King Menelaus and King Agamemnon are asking Odysseus to join them, but he refuses. Next slide. So the god of air, Ether, curses his son with Ondine's curse in order to force Odysseus to go to fight in the Trojan War in order to save his son. Next slide. So Ondine's curse is based on a different Greek myth where a water nymph falls in love with a human. They get married, and in his vows he states, "My every waking breath shall be my pledge of love and faithfulness to you." But then he cheats on her. And because of that, he loses his automatic control of his breathing, robbing him forever of any rest or sleep. Next slide. So Ondine's curse can be caused by a stroke. Autonomic respiration is driven by levels of carbon dioxide, oxygen, and the pH of both the blood and the CSF. The respiratory centers are mainly in 3 locations. There's inspiratory neurons near the solitary nuclei in the medulla. There's the ventral respiratory chain that extends from just below the cranial nerve 7 nucleus down to C1 and within the dorsolateral pons. Ondine's curse, or central sleep apnea, can occur with posterior inferior cerebellar artery strokes, anterior spinal artery strokes, or basilar territory infarcts. In the bottom right is a picture of a middle-aged gentleman who suffered a posterior inferior cerebellar artery stroke. This caused a Wallenberg syndrome, but then when he went to sleep, he developed hypercarbic respiratory failure and ultimately had to have a tracheostomy placed and had to be hooked up to a ventilator anytime he even took a nap. Next slide. So Odysseus, in order to save his son, he goes to Troy and fights in the Trojan War. The Greeks win, and now Odysseus and his men are going to journey home. And that's when the Odyssey formally starts. Next slide. On their way home, they stop at the island of the Lotus Eaters. And there, his men forget all about the Trojan War and all about their families at home. And they're just living entirely in the moment. And they just love it. They love it so much that they refuse to leave, to the point that Odysseus actually has to physically take them into his ship, tie them down, and take off. So what happened to Odysseus's men? Next slide. Well, perhaps they were suffering from ischemic amnesia. So if you have a stroke within the Papez circuit, that's your memory circuit, or neighboring structures, then it will produce anterograde amnesia, meaning that anything beyond 30 seconds is basically lost. You cannot form any new memories. And it's sometimes associated with retrograde amnesia. That can be pretty severe, sometimes decades, where you just lose all the last 10, 20 years or even more. The posterior circulation is involved in 92% of cases, and it's cardioembolic in 50% or so. This is different than transient global amnesia, which is transient and lasts less than 24 hours by definition, but usually around 5 hours. And the pathophysiology there is not as clear and thought to be, well, it could be ischemia, vascular congestion, seizure, or migraine. Next slide. So Odysseus and his men, they do finally leave the island of the Lotus Eaters, and they come to the island of the Cyclops. And there, his men start making all of these really inappropriate jokes. And they're just joking and joking and joking to the point that the Cyclops gets angry and he starts to eat the men. So what happened to his men? Why were they joking so much? Next slide. Well, perhaps they were suffering from Witzelsucht, which is pathological and compulsive joking. So this is usually caused by bifrontal lobe injuries and is typically associated with behavioral variant of frontotemporal dementia, but can happen in stroke, and as is demonstrated by this case report. So this case report was taken from another middle-aged guy who suddenly, very, very suddenly, started to compulsively joke to the point that he was waking his wife up in the middle of the night to tell her dirty jokes. And she finally made him write down all the jokes. And when he filled a notebook full of 50 pages, she said, well, now it's time for you to see a neurologist. And so pictured here, so the patient had a right frontal stroke, but also a left caudate stroke. And then in the table are some of his some of the jokes that that he was writing down. We don't need to read them. All right, next slide. So in order to get away from the Cyclops, Odysseus is said to have stabbed him in his only good eye, blinding him. But did he really stab him? Next slide. Or perhaps the Cyclops was suffering from an untreated systemic autoimmune disease, like granulomatosis with polyangiitis. This used to be called Wegener's, but Wegener was a Nazi, so we renamed it. And ocular or orbital manifestations can occur in 50% of patients. It's usually caused by C. ANCA against PR3, which causes neutrophils to degranulate, leading to granulomatous inflammation and vasculitis. And the treatment is usually high-dose steroids and cyclophosphamide for severe forms. At the top of the picture on the left are the eyeballs, and you can see that they're just surrounded by all of this extra tissue, and that's actually granulomatous inflammation that's choking off the optic nerve and can be extremely painful, kind of like feel like you're being stabbed in the eye. Next slide. So, but fortunately, Odysseus and his men managed to escape right before the Cyclops hurls a mountain onto their ship. And next slide. But Odysseus and his men are still being blamed for blinding the Cyclops. And the Cyclops is the son of Poseidon, the god of the sea. And so they are beset by several more storms and end up having to crash land. Next slide. They land at the Enian island of Circe. And Circe is the daughter of the great Titan Oceanus. And at first, Odysseus and his men are scared to death of all these wild and terrifying beasts that surround her. But then they realize that they're all tame and they accept her food and drink and are having a great time. Next slide. But that's when Circe turned all of Odysseus's men into pigs. Next slide. Or did she? Perhaps instead Odysseus was just suffering from Frigoli syndrome, which is delusional misidentification. This is named after the famous comedian Leopoldo Frigoli, who kind of made his mark by doing impersonations. It involves lesions to the uncinate fasciculus, which connects the inferior frontal lobe and anterior temporal lobe, and it's typically in the right hemisphere. And it's theorized to result from a faulty connection between emotional value and familiarity with an external stimulation. Versus, there's another theory where perhaps it's caused by disinhibition of the left hemisphere. As Joan was saying, the left hemispheres are a very rational hemisphere. And so when it's kind of left up to its own devices, it can over-rationalize and sometimes confabulate. Next slide. So in order to, finally Circe lets Odysseus and his men leave. And, but she says, before you go, you need to cross the river Styx and go to Hades. because the blind prophet Tiresias has a message for you. So that's exactly what Odysseus does. Or does he? Next slide. Perhaps instead he was suffering from Cotard delusion, which is the belief that one has lost body parts or is actually dead. And so, and this is has been described as in stroke patients who have suffered right insular or right temporal strokes. And pictured here is a hemorrhage within the right insula that kind of extends into the caudate and also has a little bit of and is also affecting a bit of the temporal lobe. Next slide. So Odysseus, he meets with the blind prophet Tiresias, and he also, while he's down there, down in Hades, he meets with some dead family members and the dead king Agamemnon, but the blind prophet does have a message for him, and he tells him that Poseidon will continue to haunt him, and be sure not to disturb the cattle of Helios. It's the god of the sun. Next slide. So Odysseus and his men take off, and again, they have to battle many storms, and then they get caught in a whirlpool that makes them spin round and round and round. But were they really in a whirlpool? Or, next slide. Perhaps they were suffering from Susak syndrome, which is a very rare autoimmune disease that causes damage to the microvasculature of the brain, inner ear, and retina. The classic triad is severe unilateral or bilateral sensorineural hearing loss, sometimes with really bad vertigo, branch retinal artery occlusions, and encephalopathy. The classic MRI lesion is shown in the bottom right. You see the white arrows point to these kind of snowball lesions within the corpus callosum. And on the top left is a picture of the retina with fluorescein angiography. And the white arrow points to a branch retinal artery occlusion, and the left arrow points to contrast uptake within the vessel wall, because this is a vasculitis. I think actually Ashton Kutcher might have this disease. Next slide. So part of this syndrome also includes encephalopathy, and so perhaps the Odysseus's men were hallucinating when they saw the monsters Scylla and Charybdis, and it is a very serious disease, and 6 of his men die. Whether or not they were, or perhaps they were actually eaten by those monsters. Next slide. Now, part of Susak syndrome does include very severe hearing loss. And if it's bilateral, then perhaps the Odysseus's brain was deprived severely of stimulation, which led to this kind of release phenomenon that made him have hallucinations. And so perhaps instead of hearing that beautiful siren song that made him want to tear off his ropes and dive into the water, maybe actually it was just Charles Bonnet syndrome. In one study, 2.5% of patients with severe audiological impairment endorsed musical hallucinations. Well, the Odysseus gets away from the sirens, and next slide. They end up at the island of the sun god, Helios. They find his cattle, and they quickly make hamburgers, which of course they were told not to do. This angers the sun god, and he destroys their ships, killing all of Odysseus's men, but Odysseus survives. Next slide. And manages to wash ashore at the island of Ogygia, where he meets the nymph Calypso. And Calypso becomes extremely attached to Odysseus, and just is very, very jealous about him and wants to force him to marry him and basically forces him to stay there for 10 years. Next slide. Well, perhaps Calypso is suffering from Othello syndrome, which is pathological jealousy. This has been described in case reports of patients suffering strokes to the right temporoparietal and insula, and it's sometimes associated with erotomania. Next slide. Well, Odysseus gets away from Calypso and he returns home where he finds that there are a bunch of suitors that are trying to win his wife's hand in marriage, Penelope. And he again is afflicted by Fragoli syndrome, thinks that all of these suitors are actually his old enemies from the Trojan War. And who did they think they were fooling? This is the guy who invented the Trojan horse. So he kills all of them. Next slide. But Penelope doesn't recognize Odysseus. She sees him, his shape, and she says, yes, you look like Odysseus, but you are not Odysseus. You're an imposter. And it's only when he tells her the story of how he built their marriage bed out of olive trees that she realizes that, yes, this is indeed Odysseus. Next slide. So what was happening to Penelope? Well, perhaps she was suffering from catgrass delusion. And so this is in catgrass delusion, what happens, or what's thought to happen, is that when you see somebody you love, so in this case, Penelope seeing her husband, they recognize that, yes, you look exactly like my husband, but there's not that warm feeling. There's not that emotional connection that she's expecting. And so she thinks that he's an imposter. But when she hears his voice, well, that connection from the auditory cortex to the limbic system is perfectly preserved. And so she recognizes that, yes, this is indeed my husband. This has been described in stroke victims who suffer lesions to the inferior fronto-occipital fasciculus, disconnecting that face processing area from emotional response areas, and usually involves the left retrosplenial cortex and right frontal cortex. It's usually a two-hit kind of thing. Next slide. So finally, at the end, everybody lives happily ever after, and that's the end.
Wonderful, Dr. Laban. Thank you so much. That's such a fascinating and amazing case story. So I appreciate it. We have a few more minutes for questions. If anybody has any questions for our presenters, Dr. Laban or Dr. Danya or Joni, please feel free to put them in the chat. Otherwise, you can press *6 to unmute your line. We will also have a link to the survey placed in the chat. Remember to click on the chat bubble in order to view the chat box. And upon the completion of the evaluation, you'll receive a 1.0 contact hour for this presentation. Are there any questions for everyone? Or anyone, I should say.
This is Angela. I don't have questions, but all three presentations, thank you so much.
Thank you.
Yeah, really enjoyed them all.
Like we have one raised hand. Oh, okay, there is a question in the chat. Let's see. From for Joni. Okay. Sorry, my chat is. Okay. Joni, they're wondering, how was the elderly woman's arm after that terrible break?
Oh, those are easy to fix. Straighten them out and put them in a splint and send them on their way. So she did quite well. Thanks for checking, though.
I was kind of wondering the same thing, actually, Joni. So thank you for that. That makes me cringe every time. I've seen that myself. It's not fun, but I'm glad she didn't feel the pain, at least initially. So, Anyone else? Well, again, thank you so much for everyone for joining us today. And thank you to Dr. Laban, Dr. Dania, and Joni for your wonderful presentations. Thank you for filling in our theme on Halloween. Oh, we do have one. Dr. Laban, how long have these syndromes been identified in the literature?
Well, I think several, I mean, most of them over 100 years old. And yeah.
Wonderful. Perfect. Anyone else? All right. Well, if anybody comes up with any questions, please don't hesitate to email us at health.stroke@state.mn.us. We'll be happy to put you in touch and get your questions answered. And that's all we have for today. Please stay tuned to your emails and our monthly educational opportunities. Stay well and take care and have a great Halloween.